So, good evening, everyone. So, I thought that I'll make a separate video on diagnosis of epidermolysis bullosa. The video is important because we are discussing the genetic epidermolytic disorders, namely epidermolysis bullosa simplex, junctional, and the dystrophic groups. And before we further discuss the dystrophic group, or we discuss the clinical aspects of individual groups of epidermolytic disorders, I thought that I'd make a short video on the diagnosis of epidermolysis bullosa. I did receive multiple emails saying that we should also discuss approach to disorders, and that becomes difficult on YouTube where you cannot even show photographs, and it becomes difficult to discuss different cases in the absence of clinical pictures. But let's see if we can find a way to bypass this hurdle that we are having to discuss things on YouTube. Now, whenever you will get a short note or a long answer type of questions on epidermolysis bullosa, you have to discuss how to diagnose a case of epidermolysis bullosa. Now, most of the diagnoses that we usually make in clinical settings are clinical. That means we just use our eyes or just examination findings and our own clinical experience to diagnose a case in case of epidermolytic disorders. But there are other modalities like electron microscopy, immunofluorescence techniques, genetic mapping, and I will cover all of these modalities in a very brief manner, so that we may be able to know a bit about them and we can write a full-fledged answer while discussing epidermolysis bullosa. Okay, so we must remember that most of the time the diagnosis is made clinically. Okay, so it is mostly a clinical diagnosis. That means the moment you see the child, you know that they are suffering from at least the parent group of epidermolysis disorders. Okay, you may have difficulty in delineating the disorder into the simplex type, junctional type, or the dystrophic type, but at least in the first instance, you'll be able to understand that the patient might be suffering from epidermolysis bullosa. So most of the time, you will see erosions. Okay, most of the time you will see erosions mostly on the trauma prone sides, or they will have a certain localization. For example, if it is generalized over the body, then you are dealing with a generalized form of epidermolysis bullosa, or if it is localized to the acral areas, then localized form of epidermolysis bullosa. Okay, so these kind of examination findings are very important to at least diagnose the case as epidermolysis bullosa, and then further and further utilizing the individual characteristics of disorders, we can easily understand and divide the cases at least into simplex, junctional, and the dystrophic type, or maybe Kindler syndrome or other different type of subtypes. Okay, so through this video, we'll learn how to diagnose a case of epidermolysis bullosa, and without much further ado, let's start with the presentation. So the diagnosis is very difficult in EB, and when I say diagnosis is difficult, that is because many of the different subtypes of EB, that means even within one big group, that means different subtypes of epidermolysis simplex have overlapping features, or there can be overlapping features between the junctional EB and simplex EB or dystrophic EB. And because of these kind of overlapping features, we might have difficulty into segregating patients into individual subgroups. Now, all of these features depend on the level of split. Okay, so by level of split, we mean if the split is happening at the base of the basal keratinocyte, or it happens at the hemidesmosomal level, or it happens at the level of lamina lucida, lamina densa, below lamina densa, or at the level of the dermoepidermal junction. So depending where we have the where we have the split, we have individual characteristic clinical features. Okay, and when we have those clinical features, phenotypically in the patient, they will appear as different clinical morphologies. For example, in the level of or as we are discussing EB simplex, then the level of split is very superficial. It's at the level of the base of the basal keratinocytes. So if we make a rough diagram again, this is a keratinocyte. Here we have the hemidesmosomes. Here we have the integrins and bullous pemphigoid antigen 2. Then we have laminins, and then we have the anchoring fibrils. So this is papillary dermis, this is lamina densa, this is lamina lucida, and these are the basal cell layer. Okay, and this whole formulates the basement membrane zone. Again, we have discussed basement membrane zone in quite a detail in previous 3 videos on the channel. So if you want to revise or learn more about BMZ in crystal clear detail, go and watch those part 1, part 2, and part 3. So in the case of EB simplex, the split is superficial, a bit above or the initial layers of BMZ at the level of basal keratinocytes. And because of that, the structures which are damaged is only the epidermis. Let me change the color. Yeah. The structure that gets damaged is only the epidermis. So most of the time, the erosions that you will see simpler erosions, they're not that deep, and they will heal with pigmentary abnormalities, seldom scarring. Okay? Scarring happens when you breach lamina densa. If lamina densa is breached, so they will heal most likely with scarring. If we're discussing junctional EB, then the split, this is EB simplex, junctional EB. The split happens at the level of laminins, that means lamina lucida and densa, in between them. Here, if the lamina densa is breached, you will have scarring. Otherwise, you won't have scarring. So there are different subtypes of junctional EB, which we have discussed in the last week's video. And there is a subtype in which the split is very superficial. So in spite of being a junctional EB disorder, it will present as a EB simplex clinically. Clear? In dystrophic, it is much below at the level of lamina densa and below lamina densa, and here you will have significant scarring. That is why the name dystrophic, significant damage. If this damage occurs at the level of skin, you have erosions. If this damage occurs at the level of nails, you have dystrophic nails. Significant dystrophy of nails will lead to nails shedding and loss of nails or anonychia. That is why when you move from EB simplex to junctional to dystrophic, you have more anonychia, more nail abnormalities, you have more scarring, you have more features or destruction as you move down from simplex junctional to dystrophic. Okay. The clinical diagnosis also depends on the defect in proteins. Sometimes the protein is, uh, dominantly inherited, but the level of defect is significant. So the whole protein is not working properly, and you have the split is complete. While sometimes the defects are not completely, the protein essentially doesn't lose its function, complete function, and it might sustain some amount of functionality, leading to decreased levels of clinical phenotype. So what I'm trying to say is, let's take the example of junctional EB. Now in junctional EB, let's say in the severe form, the defect is very severe. And that is why the name severe. That is why you have severe phenotypical appearance. The defect might also be intermediate, or the level of destruction of the protein is not complete, and here you will have a less severe phenotype. So even this being junctional EB, but if the defect is not complete, you can have a intermediate phenotype compatible with life, while certain cases of EB simplex can have significant defect and can be lethal. For example, EB simplex with lung abnormality, okay, can have lethality, or EB simplex with Kelch mutation, in which you have cardiomyopathy and arrhythmias can have lethality. So depending on the defect in proteins and the level of defect in proteins and the level at which the defect is present, you can have different kind of presentations. In the end, the question lies on genetic abnormalities. Okay, what kind of mutation is present? What kind of mutation in what kind of protein is present, and how much it is translating into the function of proteins? This is how you decide whether the patient belongs to a simplex, junctional, or dystrophic group. Okay, that is how you decide. Now remember that the current classification of simplex, junctional, and dystrophic is a very crude classification. Okay, this was entirely based on clinical classification, clinical features, and because of that, there is a significant overlap between different kind of EBs. So you have significant overlap. Okay, so that is why I believe in the coming years, when we understand a lot more about EV, this kind of classification will be lost. And even the Rook's 10th edition does use simplex junction and dystrophic, but in the simplex junction and dystrophic, they are now not using the term generalized, okay, or they use the term generalized autosomal dominant, generalized autosomal recessive, these kind of terms, okay. So the classification of EB is significantly changing, and I believe in the coming few years it will change a lot, and we will have a new classification of EB simplex. Oh, sorry, EB group of disorders. Let's move forward. So, diagnosis of EB group of disorders is essentially covers all of these major headings. You have the clinical examination and proper history taking. Okay. Now, in clinical examination, most of the information you will get from history taking, examination, and family history charting. In family history charting, you use pedigree analysis or just pedigree to find out whether the disorder is autosomal dominant, autosomal recessive, or sporadic. Okay, so sporadic mutations can also occur causing EB group of disorders. So this is the most basic form of diagnosing EB, and this is what we use in our OPDs. Okay, a part of clinical examination is EB matrix. Now, what is EB matrix? It is a tool. It's a clinical virtual tool. Virtual, that means we need to use a computer for that. So it is a form of Microsoft Excel sheet in which you input different symptoms and signs of the patient, and in the end, this software gives you a most probable diagnosis of the subtype of EB which the patient is suffering. Okay, so this was developed at AIIMS. I'm going to give you the link to download EB Matrix and understand it much better. But what exactly is EB Matrix? We'll discuss in the subsequent slides. The second is skin biopsy, that means to take a sample. The third is immunofluorescence microscopy, in which you have the antibodies. Let me just write it again. You have antibodies against specific proteins, so that you can find out whether those proteins are in their normal number, increase, decrease, or even functional. For example, you want to find out whether the bullous pemphigoid antigen 2 is present or not, or let's say whether integrin alpha 6 beta 4 is present or not. So you label a biopsy sample with antibodies against integrin alpha 6 beta 4, and then using fluorescent microscopy, you see the sample. If integrin alpha 6 beta 4 will be present, you will see a fluorescent band, otherwise, you will not. Okay, so we'll discuss that in subsequent slides. The fourth is transmission electron microscopy. This is considered gold standard. Here you actually see those proteins. You actually see the split, so that you can know what exactly is the level of split. And you also see tonofilaments or crumpled up keratin filaments. So these are also seen. Okay. And the fifth is genetic analysis, which can tell you about what protein is mutated. But remember, presence of a mutation doesn't mean the child will have disease. And if you're not doing whole exome sequencing, you might miss new mutations. And in EB's group of disorders, new and new mutations they keep coming out in literature. So if you miss mutations, you might miss a diagnosis of EB simplex on genetic analysis. And if, let's say, you have a mutated gene on genetic analysis, that does not necessarily mean that the patient is suffering from uh, a certain disorder, because even if the gene is mutated, the gene eventually doesn't get translated, or might get translated, might not get translated. So there are a lot of variation between genetic mutation and its phenotypic presentation. Okay, and this phenomena is known as incomplete penetrance. That means the gene is not able to completely penetrate. So if you have a mutation, It may or may not translate into a defective protein, leading to EB group of disorders. Clear? So let's discuss these disorders one by one. Sorry, these diagnostic modalities one by one. So clinical examination is easy to understand. Just go through our videos on EB group of disorders. So in those videos, we have discussed individual characteristic features of different groups and different subtypes. Okay. First is EB simplex. EB simplex, most disorders are autosomal dominant but rarely recessive. Inheritance you will understand by doing pedigree analysis or just taking a good family history. So in EB simplex, I'm sorry. In EB simplex, you have localized blisters or grouped vesicles, very limited mucosal involvement, palmoplantar hyperkeratosis, nail dystrophy is present, but they are not as severe as other groups of EB. The teeth are normal and hair is also normal. Okay. If we discuss junctional EB, okay, the second is junctional EB. Most of the disorders of junctional EB are autosomal recessive. Okay. And in junctional EB, you have widespread blistering. The blistering is very widespread, a large area is involved. Scarring, granulation tissue is present specifically on the erosions and around the nails. Severe mucosal involvement, dental pitting, alopecia, nail dystrophy, which is severe, more severe than the simplest group. Okay. The third is dystrophic group of EB. Both autosomal dominant and recessive forms can be seen. It is presented with hemorrhagic blisters. Okay. Hemorrhagic blisters. Now, understand in dystrophic EB, the level of split is very low. So, it can even damage the blood vessels present at the papillary dermis level. And because of that, you can have leakage of blood inside the bulla. So, you have hemorrhagic bulla. Scarring is there because lamina densa is breached. Milia is there because lamina densa is breached. Pseudosyndactyly because there is significant scarring. Severe mucosal involvement. Okay. Physical retardation, significant morbidity and mortality. Okay. So these are the ways in which you can segregate different disorders or different groups of disorders at least. Okay, so you have localized blisters, palmoplantar hyperkeratosis plus minus nail dystrophy, limited mucosal involvement. In junctional, you have widespread blistering, scarring, granulation tissue, severe mucosal involvement, dental pitting, alopecia is important. Okay, in dystrophic EB, you have hemorrhagic blisters, scarring, milia, pseudosyndactyly, severe mucosal involvement. Okay, significant morbidity and mortality. Okay, so in just clinical examination of the patient, you can easily understand to which group the patient belongs to. Let's move forward. This picture I've already discussed while discussing EB simplex. This is used here just to show you that as we move from EB simplex to junctional EB to the dominant dystrophic EB to recessive dystrophic EB, the symptoms like scarring, milia, nail dystrophy, all three findings, they show a gradual increase as we move from one group to other. In short, as the level of split goes from superficial to deeper aspects of basal membrane zone, the deformities in the form of scarring, milia, and nail dystrophy all increase, the symptoms increase, the severity increase. And you can see the none graph goes below or goes to zero till as we move from ABS to other groups. So ABS can have none of the deformities, but the major deformities in the form of scarring, milia, nail dystrophy, in fact, other deformities like teeth enamel abnormalities, teeth enamel pitting, loss of nail, severe mucosal involvement, all of these not extracutaneous, but all of these severe manifestations, they increase as we move from simplex to junctional to dominant dystrophic to recessive dystrophic. Okay. So this diagram is just to highlight the increase in abnormalities. Let's move forward. Okay. So coming to the EB metrics, as I said, it's an MS Excel program in which you just input the different symptoms and it gives you the most probable diagnosis. Okay. Now this is known as onion skin approach. Onion skin approach means that layer by layer you try to diagnose what the disorder the patient is suffering by layer. Okay, so individual layer. Okay, so that is how you try to diagnose what is the exact disorder. So if you have a child suspected of EB, you assess with clinical features and make a differential diagnosis. You do a skin biopsy to find the plane of cleavage. You identify the affected protein using immunofluorescence. You do electron microscopy for inconclusive cases after immunofluorescence, and then you find this suspected gene and specific mutation. Okay. So what EB matrix does is it enhances the assessment of clinical features to give you a most probable diagnosis. That is why EB matrix is best suited to create differential diagnosis before sending the sample for either immunofluorescence or genetic analysis. Okay, so it creates a good list of most probable differential diagnosis in a child suffering from EB. Now this is a very simplified version of the matrix. This is how it looks like. You look at the features like distribution of skin lesions, excess granulation tissue, scarring, milia, nail dystrophy, nail loss, mucosal erosions, eye involvement, hoarseness, microstomia, poor dental enamel, keratoderma, chronic wounds, syndactyly, alopecia, poikiloderma, relative growth failure, survival after 2 years, and if parents are affected or not. And in each of the disorders, you just write if it is like +1 or +2, or you have different kind of options that you can choose from. Okay, and at the end of that, the software combines all the features and give you the most probable diagnosis. So this is how a dashboard of EB matrix looks like. Okay, you just compare your patient with the pictures that is given. And when you compare those pictures to the patient, you just have to choose any one of these options. And then you click next, and a different set of pictures are shown, and you match your patient with the pictures and choose the option and keep on choosing till the matrix is finished. At the end, when the matrix is finished, it will give a score to each of these features, and the column with the highest score is the most probable diagnosis. So in this example, the most probable diagnosis is EB simplex generalized severe type, because the score is highest in this column. It is 19. So this is how a matrix work. It takes care of 19 parameters, and scores are given on the basis of what options you choose while matching the pictures with the patient, and then gives a combined scores and tells you the most probable diagnosis. So here we can also see that junctional EB generalized intermediate type and the generalized intermediate EB simplex type have the same scores, but we have to deal with the maximum scores. If most of the scores come out to be close to each other or same, then it is inconclusive, and then you send it off for further analysis by immunofluorescence or genetic mutational analysis. Okay, let's move forward. Now, after clinical examination, you decide to do skin biopsy to find the level of split. So to find the level of split, where exactly is the level? If it's a level of basal keratinocyte, below the epidermis and above the dermis, or is there a level of papillodermis or sublamina densa? Now it is not so useful. Why it is not so useful? Number one, we are dealing with basement membrane zone, that is very thin layer or a very thin area to be examined, and this is not so clearly seen in HNE, in H and E. Okay. Second, there can be not tractional, but there can be artifacts. For example, the sheer act of forming the blister, taking a biopsy can lead to artifactual splits. Okay. Or in differential diagnosis or other DDs of splitting disorders, maybe like childhood pemphigus or something like that, you can still have a split. And you can think of this as EB, but the skin biopsy might not help it. Number three, it doesn't tell you the specific mutations. Of course, it cannot, because it is a skin biopsy. But the advantages of doing a skin biopsy is it's quick, it's easy, even residents can do it. It's the most basic histopath examination. And the level of split, if you can clearly see, you can find a good differential diagnosis just on the basis of a skin biopsy. So these are the advantages and these are the disadvantages. Clear? Now we use the technique known as eraser biopsy technique. In eraser biopsy, you take a pencil eraser. So you have a pencil like this. You have the eraser at the end. So you are just supposed to put the pencil, like if you have this pencil, you have to put it on the skin and rotate it for 10 seconds so that the hair area becomes a bit bright, not bright, a bit red, but there should be no blister on the side, okay, just red. And then you take a biopsy, a punch biopsy, and you examine and see the level of split where it has separated, where the layers have separated, okay. Now you rotate it for 10 seconds, that's more than enough. Make sure no blister is formed, only erythema is good, so blister no, erythema yes, okay. And it is good idea to have a excision biopsy. Why excision biopsy? Because even if you have erythema, maybe the features are better seen at the margins. So instead of taking a punch in between, a punch biopsy in between here, it's better to excise the erythema tissue and then send for biopsy. Okay. But of course, if we are doing in OPD settings, we need an easier approach. So we end up taking a punch biopsy. Also, you need quick sampling. The sampling has to be very quick. Within 24 hours, it should be sent for HNE and examined so that there is no artifactual splits in the epidermis. Let's move forward. In immunofluorescence microscopy, it is important to understand the basic principle behind immunofluorescence microscopy. Now, what exactly we do is that we stain the dermoepidermal junction or other junctional complexes. Okay. For example, if we have anti-type 4 collagen antibody, that means antibodies against type 4 collagen, then we can use it to stain lamina densa. We know that lamina densa predominantly has type 4 collagen. If you want to read more about it, you can see the type, not type. I'm so sorry. If you want to know more about lamina densa, you can see the part 3 of basement membrane zone. So we know from that video that lamina densa predominantly has type 4 collagen, and if we use an anti-type 4 collagen antibody, it will attach itself to collagen 4 and stain the lamina densa. Okay. Now after staining the lamina densa, if we create a blister and the blister shows immunofluorescence at the roof, that means the split is below lamina densa. Okay. For example, let me just tell you like this. Let's say this is the epidermis and dermis. Okay. We stain lamina densa using anti-type 4 collagen. Okay. And we induce a split. After inducing the split, if we see that the fluorescence is on top, it means that the defect lies below lamina densa. The defect is below lamina densa and it is most likely dystrophic EB. Because as we know in dystrophic EB, the defect lies below the lamina densa. Defect is at sublamina densa. Clear? If the immunofluorescence is at the floor of the blister, that means it is EB simplex or junctional. For example, if we use the same example and we have the split and the immunofluorescence is at the bottom, that means the defect lies above lamina densa, and this can be seen in EB simplex and junctional because all the problem lies above and over lamina densa. Clear? Let's move forward. Now, anti-typhocollagen antibody is just one out of many antibodies which can be used in immunofluorescence microscopy. You can have individual antibodies against bullous pemphigoid antigen 2, against integrins, against plectins, against plakophilins, against exophilins, against different types of laminins, so that you can individually stain the layer and see whether it is present or not. Immunofluorescence microscopy is not used to find the not find number or concentration. Because for that you need to have a normal sample to compare. Let's say a normal sample of skin has 100 units and a sample from EB simplex has 40 units. So you can label it as EB simplex. This is not done in immunofluorescence microscopy because you understand that the genetic mutation is going to be there in all the cells. So there is no point. There is no way that you can get a normal skin biopsy from the same patient to compare. Exceptions do occur in the form of revertant mosaicism. Okay, but we don't use immunofluorescence microscopy to find out whether the number is reduced or not. We just use it to find out what genes are, what proteins are if defective, and what is the level of split in the sample. So if we want to know the level of split, blister is essential. We need to have this defect to find out whether it is the roof which is colored or it is the floor which is colored. Okay, let's move forward. So here you can easily see that the type 4 collagen is stained over. Okay, it is staining the roof of the blister. This black one is blister and the roof is stained. That means the sample is taken from a dystrophic EB child because the defect lies below lamina densa. Clear? So this I've taken from Rook 69.21. You can go and see the picture and read the explanation. But the explanation essentially says that since the stain is at the roof of the blister, the defect lies below the roof, and that is why it is from a patient of dystrophic EB. In this diagram, in this immunofluorescent micrograph, you compare the lesional biopsy with a control biopsy. In control biopsy, you can see that the level of lamina densa is stained perfectly. But when we compare it to the patient sample, we don't see this band. This band is absent. And when this band is absent, you usually see that in recessive dystrophic EB. Okay. So as I've said earlier, that you don't use to find out reduced number, but you can use it to find out whether it is present or absent. So plus or minus can be seen, but not reduced number. So you compare it with the control, see the absence of the immunofluorescent layer, and make a diagnosis that the patient might be suffering from absence of a particular protein. Most likely it is seen in recessive dystrophic epidermolysis bullosa. We'll discuss RDEB when we'll be discussing dystrophic epidermolysis bullosa next week. Now, transmission electron microscopy is considered the gold standard. This could be a good Viva question or a quiz question, that what is the gold standard in diagnosis of EB group of disorders? That is transmission electron microscopy. So apart from getting the level of split, you can see the split in electron microscopy also. You can even see acantholysis or acantholytic cells. You can even see defective proteins. But there are other different specific features. For example, ball-like clumping of tonofilaments in basal keratinocytes. So if you remember our video on EB simplex, I have told you that sometimes the keratin mutation leads to clumping of keratin filaments or tonofilaments. And this clumping is responsible for the severity of defect. And that is why, especially in disorders like EB simplex generalized severe, you have the clumping of tonofilaments. So in severe EB simplex, on electron microscopy, you can actually see the clumping of tonofilaments. Clear? So this is one feature which has been described. Second is pallor and lack of tonofilaments in basal keratinocytes. In this, you see recessive mutations in keratin 14 or dominant mutations in Kelch type protein. Now, these are all EB simplex subgroups. EB simplex. But in recessive forms of EB simplex, the protein will be essentially absent. So you will have lack of tonofilaments. You understand the concept? In a normal cell, you have tonofilaments. If the cell shows clumping of tonofilaments, that means it is severe EB simplex because they are so defective that they have clumped together. They are not separate fibrils like normal cells have. If the tonofilaments are entirely absent, then it is because it is a recessive mutation in EB simplex, or the mutation lies in the Kelch protein. Kelch protein is responsible for, if you remember the part 1 of the series, EB simplex, it is responsible for auto ubiquitination. Excuse my handwriting, but go and see the part 1 of the video. So what ubiquitination is to mark the protein for destruction, and Kelch mutation auto ubiquitinizes keratin 14. Keratin 14 and keratin 5. Okay, so keratin 14 and keratin 5 are erroneously marked for destruction and they are destroyed. So that is why you don't have tonofilaments on electron microscopy. Clear? If you have any issues in understanding the concept, just let me know and I'll explain in the comment section. Okay. Grouped perinuclear vesicular endosomes are seen with exophyllin 5 mutation. This could be a good viva question or a quiz question. Intracellular stellate bodies is seen in self-improving dystrophic EB. We'll discuss that next week while we will be discussing dystrophic EB. And this could be a very important question for match the following, isn't it? I mean, if I would be creating a question, I would create a question out of this slide. Match the following features with disorder on electron microscopy. Let's move forward. So here in this picture of electron microscopy, which I've taken from Rooks, you can see here are the tonofilaments which are clumped, which have formed a group. So clumped tonofilaments. The asterisk marks the defect where the split has happened. So here you can see the split. Here you can see the split. Here is the split. Here also the split. And clumping of tonofilament with split present at the level of basal keratinocyte, because here you can see nucleus. So we are still in the basal cell. If the split is at the level of basal cell and you have clumped tonofilaments, you can easily make a diagnosis of EB simplex generalized severe. So this is the example that Rooks have chosen. So I'll use the same picture to explain the concept of transmission electron microscopy. Let's move forward. Now, DNA sequencing, also known as Sanger sequencing, it has been postulated that about 16 genes are mutated in EB simplex group of EB group of disorders. Some articles mention 18 genes to be defective, but as high as 40 genes have been reported in literature with individual mutations to cause EB group of disorders. And time and time again, newer mutations are being identified and reported. Okay. So we see, to understand, you need not remember all the mutations. You just need to understand where that protein is functioning. When the protein is defective, the split will be at the level where the protein is supposed to be. And if you know the level of split, you can diagnose it as EB simplex, junctional, or dystrophic type. Clear? So most of diagnostic DNA sequencing utilizes sample from peripheral blood or saliva to take the cells, and because that's the easiest way that you can have sampling instead of getting a skin biopsy in a child. It will get you a gene specific diagnosis because you're looking at the individual mutation of genes. So what gene is mutated, you can easily find. For example, let's say you find a mutation in plakophilin. So you have an idea that it could be EB simplex. You have mutation in exophyllin 5. You have an idea that it is EB simplex, isn't it? Now, that is how you can use DNA sequencing, but the major disadvantage is that it is being done only at academic institutions. That means at the level of research. Okay. Most of us don't even know that where we can send a sample for DNA sequencing. So it's done mainly for research purposes. As other disadvantage is cost, but that is rapidly coming down with newer technologies. So we might have an affordable way of sequencing DNA for EB group of disorders, isn't it? The newer thing about it is next generation sequencing, in which you sequence the whole exome for all the mutations. In other words, you analyze and scan the whole genome, the whole genetic material or the exome. Exomes are the genes that actually get translated. Okay, so you have a sequencing of whole exomes, and you then compare it with normal exomes and find out which exome has mutated. Okay, leading to the disorder. The major disadvantage is that it takes weeks to months. Disadvantage is that it takes weeks to months. It's a very time consuming procedures. For example, skin biopsy can take like a day or two. Electron microscopy maybe take 1 or 2 weeks. Okay. But DNA sequencing can take 1 to 2 months easily. So it is costly, time consuming, but gives you the perfect diagnosis, isn't it? Another newer modality, so next generation sequencing is one. Another newer modality is RNA sequencing. So in RNA sequencing, instead of looking at the mutation of genes, you look into the mutations of RNA. Okay, so remember you have a gene. With gene you have mRNA. With mRNA you have RNA. With RNA you have protein. So instead of looking at mutation in the gene, you look at mutation in the RNA, and this is known as RNA sequencing. It is another newer modality in DNA sequencing in EB group of, sorry, not DNA sequencing, in genetic sequencing in EB group of disorders, RNA sequencing. Let's move forward. So this is an example which Rooks uses, the 10th edition uses at page 69.23. So here you see a normal sequence of DNA, and here you see from a EB child, EB child. And here you can see that this G here, is absent here and is replaced by a nonsense mutation. And because of absence of G, this spike that you usually see in DNA sequencing is lower, it's decreased. And the codons are all stopped because this is known as premature termination of RNA. So what actually happens is, the normal protein is GACCC, GGGGG, TGA, GCG, understood? But if you have a codon or a mutation which leads to stopping of further translation, no new codon, no new amino acids are integrated, and the protein stops here. And when the protein stops here, the protein is defective, it's not able to carry its normal function, and you have EB. So depending on the gene which is being analyzed and the specific mutations, you can easily find what protein is affected, and then you can easily segregate with certainty what kind of EB the child is suffering. Let's move forward. So with that, we finish our discussion on diagnosis of EB. If you're writing a short note, go from clinical examination, history taking for the family, pedigree chart analysis, uh, examination of nails, teeth, enamel pitting, all sorts of other disorders, all sorts of extracutaneous manifestations. Okay, then you will go for using EB matrix, which you can easily download. The link is here. I will also copy and paste it in the description box to download EB matrix. Download EB matrix and enter details of the patient, match with the photographs to find the most probable differential diagnosis. Okay. So, for further understanding, read chapter 69 from Rooks, chapter 32 from Bologna, 60 from Fitzpatrick. But if you have gone through this series of videos, you will understand in a very simpler way EB group of disorders. You won't have to be scared by the different subtypes that you have. I will be giving you mnemonics to remember each and every one. This is a good article to get a basic understanding of epidermolysis bullosa, but you may read it, but I've integrated nearly every factors that were mentioned in the article. And this is the parent article of EB matrix. So you can read how the matrix was formed and what all features were chosen, how it was back tested on patients. And it's a very important clinical tool. Most of us don't even know about it. Uh, we used to get questions in our exams on EB matrix. So it's an important tool. It's a very important tool. I personally know the person who did the research, Vamsi K. He's a very nice chap. So learn about EB matrix, and if you're working in a pediatric dermatology clinic or a hospital, or you're still learning at the level of residency about EB group of disorders, learn how to use the matrix. Okay, let's move forward. So this video is important. It's coming before the Delhi elections. We have our elections this Saturday on 25th of May. So make sure you take out time and record, no matter what. If your constituency lies in Delhi, you have to go out and vote. Trust me, even if you have to take a leave and go and vote, take a leave, go and vote. Okay, it happens once in every 5 years. Makes you feel important, and it's a good idea to flaunt the mark on the finger. Go outside and vote for anyone. And instead of Nota, Nota is useless. Don't do Nota here. Nota in our country is useless. But vote for any party that you desire, you think is working good. But at least go and vote. Don't just waste your opportunity into internalizing your duty in the elections. Okay. So with that, we finish this midweek discussion on diagnosis of epidermolysis bullosa group of disorders. I've covered the major headings. If you just go through this video once and then revise it by viewing it at 1.5x, you can easily have a good grasp. Just remember the headings. You know the concepts. You just have to reciprocate them in the exam. So without much further ado, you have any comments? Any doubts, any suggestions, any queries, just mention them in the comment section. I do reply to them, or you can email me, but I prefer the comment section. And if you have any doubts regarding a specific part of this presentation, make sure you mention the time and so that I can understand the context much better. Otherwise, do give us comments about how to improve in the videos that I make every week. So next week we'll discuss dystrophic epidermolysis bullosa. Till then, I usually say enjoy your weekend, but since this is midweek, enjoy the next day. Okay. So till then, we'll meet again after a few days. Adios. Bye bye.